Good afternoon, everyone. Good evening for everyone in Greece. Today, we have the pleasure to have again our medical volunteer, Dr. Nahreen Ahmed. As you met her last time, Dr. Nahreen is a pulmonary and critical care from Philadelphia. She has a very large experience with point of care ultrasound. She has participated in different countries such as Ethiopia, East Africa, and East African Training Initiative with two nonprofits such as MedGlobal and Bridge to Health. She has become the head of ultrasound in these two organizations. And between these two organizations, she has developed ultrasound training programs in Sierra Leone, Yemen, Pakistan, Uganda, Kenya, and Tanzania. And recently, she has been given the role of head of ultrasound for both organizations, as I mentioned. So Dr. Nahreen has been very involved as well in working at her hospital with point of care ultrasound. So the topic for today is a point of care ultrasound for echocardiography. So Dr. Nahreen, the floor is yours. Thank you so much for participating in this webinar.
Yeah, of course. Thank you so much for having me. So I wanted to just quickly point out a website that I vouch for. This is a good friend of mine who is actually nephrology critical care and POCUS trained. It's called nephropocus.com, and I put it in the chat as well. It's a great site with incredible cases. It's a good way to go back and refresh what we go through today. Of course, the webinar will be available for you to replay at any time, but this is a great way to expand your knowledge after today. So I just wanted to point that out for you all as well. So I'll get started. Today's lecture is basically broken down into 3 parts. And the reason I do it that way is because it's a lot of information and allows you to digest it a little bit more clearly. So I'm just gonna move this. Okay, great. So the first part of this is just the main views of the heart. What I want to point out is that this lecture is not to make you an expert in echocardiography. That's left to the cardiologist, right? This lecture is to introduce the concept of point of care ultrasound as it pertains to cardiac ultrasound and how we can use it at the bedside. And in the beginning with cardiac ultrasound, because it's much more complex than lung ultrasound, it takes quite a bit of time and practice to really become fluent in cardiac ultrasound. So these 3 lectures are going to give you an introduction, help you understand what you're seeing on the screen, why you're seeing it, and in general, help you identify some really high impact findings that will help you manage your patients in the field. So again, remember, point of care ultrasound is always asking a question. You're asking a specific question that you're looking for a specific answer to. With cardiac ultrasound, you're asking the question, maybe why is the patient hypotensive? Why is the patient cool on exam? These questions, why does the patient sound like they have crackles and fluid in the legs? You're looking for, all of these specific questions. You're trying to identify a specific answer. So that said, you remember, with all point of care ultrasound, it's not meant to be necessarily comprehensive. It's meant to really focus on a main issue that's wrong with the patient and to help you identify quickly and manage quickly. So the utility of point of care cardiac ultrasound is for rapid and dynamic diagnostic tools. So again, for categorizing shock, you have a patient that comes in who's hypotensive and you're trying to identify which etiology of shock is it. This is very important because in the field, if you do have somebody who's hypotensive, there is a difference between what you would do for hypovolemic shock versus cardiogenic. And this is a very useful tool for that. Identifying imminently life-threatening disease processes such as tamponade. So highly impactful finding on cardiac ultrasound and quite easy to find. And I think you will see that after we go through all these lectures. Massive PE. While you can't see the clot itself in the lungs, you can see the effect it has on the heart. RV strain, RV dysfunction, things like that. And of course, severe hypovolemia. How do you then use it after you intervene. You can use cardiac ultrasound to then assess the response to therapy. Now, if you were with us for the lung ultrasound talk, we can similarly do that with lung ultrasound. So remember, one of the key parts of ultrasound is that you can go back with the device anytime. You can go back to help diagnose. You can go back to then assess your response to therapy. For instance, with lung ultrasound, if you have somebody with pulmonary edema and you're giving them diuretic, you can go back and see, are the B lines less than they were before? Is my diuretic working? Other ways you could use cardiac ultrasound: identification of coexisting diagnoses. So if you have somebody who you diagnose as in distributive or septic shock, you might also be able to identify cardiomyopathy, which we see with sepsis, valvular pathology, which is a little more higher level, and we won't cover that nearly as much in this talk, aortic aneurysms and pleural effusions that might also be coexisting with LV dysfunction or RV dysfunction. And of course, with any ultrasound, remember, this has to be integrated with your bedside physical exam, your history taking, any labs that you might have, and any other ultrasound exams. The objectives that we're going to go through. So basically, one, you'll be able to identify standard cardiac ultrasound image acquisition. And that's just how do you get those 5 views, the basic views of the heart. I'm going to hopefully walk you through the common acquisition challenges. As I mentioned, initially, cardiac ultrasound is quite challenging, and those challenges are really important to know, because knowing the limitations of your imaging is really important as you go on to interpret it. And then, of course, we really want to identify these 5 E's. It's just a way to sort of generalize what exactly we're going to cover. The 5 E's are ejection fractions. We're talking about LV function, effusions, so pericardial effusions, equality, so really looking at chamber size and what that means as far as diagnostic and pathology, entrance, meaning where the IVC enters into the heart, and exit, the aortic root, and what that means pathologically as well. So with all ultrasound, positioning is incredibly important. And so one of the things that I really want to point out is that, of course, we want the ideal positioning. Ideal positioning is somebody who is in the left lateral decubitus position. The heart comes nicely close to the chest wall. That allows you to have even better images. Unfortunately, that's not always the case in clinical, in the clinical setting. Especially if you're in the ICU, the patient might be intubated, or if they're just unable to roll on their left side for whatever reason, this might not be a position that you can achieve, but it is certainly the ideal position if you can. As far as equipment, this is probably one of the most important things. Understanding the correct equipment to use will help you really get quality images. So the cardiac or sector probe, which is what you see at the right side of the screen here, it's that square-faced probe. For those of you that are using different types of machines, most of the cardiac probes look pretty similar. These are low frequency probes. So low frequency means that they go to a greater depth, and that's why we can see the heart, which is a structure that is a little bit deeper than the chest wall or lungs. So remember, with the lungs, we were using both high frequency for shallow depth and low frequency for more depth, but the cardiac probe is always low frequency for greater depth. Now, the reason that the face of the probe is the shape that it is because there's actually a pretty small footprint between the ribs and the lung in order to identify the heart. So if you can see in this picture, there are a lot of things in the way that the actual amount of space that you have in order to propagate sound waves from the ultrasound probe is quite limited. You know, if you look here, you can see that you have ribs. Remember that sound waves don't travel past ribs, they reflect back, right? You have the lungs, which causes scatter of sound waves. These are all things that kind of could obstruct your view, and it's important to know as we go on. So the next thing to talk about with the probe itself, so now that we know we have the low frequency probe is what we want to use, which is the cardiac or sector probe is another name for it. Or another name that it's referred to is the phased array probe. Now we need to know, all right, how do we hold the probe? So cardiac probe orientation can be quite confusing. And the reason for this is as follows. Cardiologists traditionally have the indicator dot, which is this green dot that you're seeing at the top of the screen here, on the right side of the screen. Emergency medicine doctors traditionally have the screen reversed with the marker on the left side, as you see here. This is an artifact of using the ultrasound for abdominal and pelvic imaging. What does that mean? That means abdominal ultrasound classically has the indicator dot on the left, and that's why emergency medicine doctors just typically keep the screen as is and traditionally leave the marker on the left side. Intensivists, which is kind of how I was trained, tend to use whichever orientation we're trained with, and that's usually the cardiology method. The really important thing, though, is just understanding what that orientation marker means with relevance to the structures that you're looking at, as long as you know which side is superficial, which side is deep, and that is probably one of the most important things. What I'm going to teach is based on the cardiology reference, which is the marker on the right side of the screen. So, as I mentioned in the beginning, there are 5 views which fall into 3 cardiac planes. So those planes are as follows. So imagine we are trying to get a 3D view of the heart so we can best characterize what is going wrong with the heart that is explaining the patient's clinical presentation. So in these 3 cardiac planes, you're imagining, the way I like to think about it is, I imagine myself almost sitting at the edge of one of these planes and looking as if I'm the ultrasound probe. It sounds somewhat silly, but it really works for me to get a good visualization. So the first plane that we're going to talk about is the long axis, and it's through the LV apex and middle of the aortic valve here. Okay, so this is the long axis plane. And as you can see, it's cutting through the long axis of the heart. Then you have the short axis, which is cutting through the short axis of the heart, and the 4-chamber view, which is basically cutting sagittally through the heart. So starting with the parasternal long axis view, and the order of these views is how I would suggest you follow, is the order I would follow when you're at the bedside. So we always start with the long axis view. So as you can see here, the transducer, the picture on the left kind of gives you a visualization of how the transducer is being held and what that plane looks like. So the transducer placement, typically left 2nd to 5th intercostal space. Remember, nobody's anatomy is equal across the board. And so we say 2nd to 5th intercostal space, and you may have to slide up and down in order to get the adequate view that you're looking for. You want to stay adjacent to the sternum, and the reason for that, again, is remember, because we have the lungs that could obstruct our view, which is going to be further lateral. And then, of course, if you're on the sternum, then that's bone, and you have to stay in between the rib spaces. Sounds like a lot to remember, but when you're at the bedside, it's definitely a little bit easier to understand. The transducer marker should be pointing towards the patient's right shoulder, okay? And that's in the cardiology convention with this on the screen, the marker is on the right side. So what you're seeing here is the patient is laying flat on their back. You have the scanner is holding the probe with the marker facing the patient's right shoulder, and that is cutting across the long axis of the heart, okay? So what does that look like on the screen? So again, you see the scanner here is holding the probe such that the dot is towards the patient's right side. And if you imagine the heart sitting in the chest here with the apex here, and then it's cutting across, you imagine that dot is creating a line from the right shoulder to the left hip, and it's cutting across that long axis, okay? Now, if you think about it like that, think about the image being on the screen. Okay, I'm going to go back for just a second. That this image that they're showing on the left side is basically what shows up on your screen. That the structures that are closest to the dot, which will include the aortic outflow tract, the RVOT is a little bit closer to that dot. Those same structures are going to be on the screen with the marker on the right side here. Those same structures are closest to the marker, okay? So what are the structures that we see in the long axis view? So again, very confusing with the orientation. And I understand that this can cause a lot of consternation, but in time, I think it will make a lot more sense as we continue on. So the first thing that you'll see at the top of the screen, remember the top of the screen represents the most superficial structure. So I'll go back again. The most superficial structure, as you see here, is the RVOT and aortic outflow tract. The deeper structures are the left atrium and the left ventricle. And that's exactly what you're seeing on the screen. The most superficial structure is the RVOT, standing for right ventricular outflow tract. So it's not the entire right ventricle, just the outflow tract. We see the interventricular septum. We see the left ventricular outflow tract and the aortic valve, the left ventricle, the mitral valve here, and the left atrium here. Okay, so pretty much this cartoon animation is basically what we're seeing on the screen here. Okay. Now, here's that exact image of the long axis view, but dynamically. So now when we see this at the bedside, how do we know if this is a good view? That's the first question. And two, if we can answer that, can we answer what all the structures are? So what do you want to see that makes it a good view? All the structures I mentioned in the slide before, if you can see those, that kind of gives you an indication, okay, I have an adequate view of the parasternal long axis. So the first thing is the left atrium, which you see here labeled, then the left ventricle, which is that cavity. Remember, anything that's black means it's filled with fluid. So here, of course, the LV cavity, you see the walls coming together, but the middle of that is black because that's blood. That's the anechoic space that represents blood. You see the mitral valve, you see the aorta, you see the aortic valve opening and closing there, you see the septum, you see the right ventricular outflow tract. And the one thing that's not mentioned here, but I'll mention it, is you can see here this circular structure is actually this descending thoracic aorta, and you can see that often as well. So now that we've identified what the parasternal long axis view looks like, what do we use it for? What is it good for? It's great for a qualitative assessment of LV size and function. And I'll talk about that more as we move forward, but this is just the key points. The RV outflow size can give us some assessments of function and size, evaluation of the aortic valve and mitral valve anatomy, and you can see that quite clearly. Left atrial chamber size, evaluation of the pericardial space and descending aorta, which you saw in the prior image. The pitfalls, however, are really important to mention here. Because you're only seeing the RV outflow tract, it can be an inaccurate assessment of RV size alone, which is why, in general, we always say you cannot make a judgment just from one view with cardiac ultrasound. You need at least two views in order to make a judgment about the pathology of the heart. One view should never be enough. The LVEF can often be inaccurately assessed if you're off axis. How do you know if you're off axis? As you can see here, the left ventricle is nice and elongated. It looks as if you would imagine all the animations to look in its true form. If it looks circular, like as if it's on the short axis, or if you're cutting the wall at a certain angle that you're not actually seeing the free wall and the interventricular septum come together, those are ways that you're off axis and might be inaccurately assessing the EF. And of course, as you can see here, you're not really seeing the LV apex, right? So there's a lot that can happen at the left ventricular apex, and it's important to know that the limitations of this view mean that those are the certain things that you can't assess. But remember, there are several other views you have left to look at. The next view that you're gonna look for, so we went from parasternal long axis view. Remember again, the dot for the long axis view is pointed towards the patient's right shoulder. Now you're going to turn into the short axis view. So basically now, as you can see, the image shows here that the dot on the probe is going to be towards the patient's left shoulder. So the transducer marker will be towards the left shoulder. And all this was that you went from a long axis to a short axis view by rotating clockwise 90 degrees. Now, what are the views that we can get from the short axis view? What are the structures that we can look at? So this is pretty much an ideal image for somebody who's looking at the short axis view. And it's something I want to point out that I should have probably pointed out earlier. I want you to focus here on how the hand is holding the probe. It's in such a way that you're holding the probe like a pencil with your 3 fingers here, stabilized on the patient's chest so that you can make very small adjustments so that you can adjust to change your view based on what you're looking for. So here's a pretty ideal image. And what you're looking for is ideally to find the papillary muscles, which are shown very clearly in this cartoon and here shown in this still image as well. Okay, and that's probably the best start, because that, as I will go into, is the area, the view that you would use in order to judge your ejection fraction. However, fanning the transducer will produce multiple views. So what does fanning mean? Fanning means that as you're holding your probe, on the chest, right, with your dot towards, and I wonder if you can see me here, with your dot towards the patient's left shoulder, fanning means that you're tilting, fanning, it's the same word, same meaning. Tilting up means the face of the probe looks up, tilting down means the face of the probe looks down. All the while your dot is still towards the patient's left shoulder. What does that do for you? Well, what it does is that it changes the views that you're looking at. If you tilt the probe upward, then you're getting a view that looks like this. Okay, and you can kind of see how these cuts will look as you continue to tilt from up to down. So at the top view, at the base of the heart, you're seeing the RVOT, you're seeing the tricuspid valve, the right atrium, the left atrium, you're seeing the aortic valve there. And then as you tilt the probe down, so the eyes of the probe are starting to look down, then you'll see the mitral valve, because that's the next big structure, right? You'll see that circular LV, and you'll see what looks like in a normal RV will look like a crescent-shaped structure. As you continue to tilt downward, you'll see the LV with the chordae tendineae, and as you continue to tilt downward, you'll see the papillary muscles, and then if you tilt all the way down, you'll see the LV apex. And these are different ways for you to look at different parts of the heart as they're affected by different pathology. Starting at the papillary muscle is probably the most important, as I mentioned in the prior slide, because that's where you're going to get the most information, especially for beginners. That's the classic spot to start. So again, if you tilt down, you're looking at LV apex. As you tilt up, mitral valve, aortic valve. And now what does that look like in real time? So here we have your aortic valve. Okay, nice and clear picture of your aortic valve. If I were to tilt downward, okay, so now I'm tilting downward from the base to the apex. Now I'm looking at the mitral valve here. This is the RV, nice circular left ventricle. As I continue to tilt down, I'm seeing the papillary muscles, so these protrusions here. And again, you see your nice circular left ventricle and your right ventricle here. And as you continue to tilt down, you see the apex of the heart, and again, your right ventricle here. So what is the parasternal short axis good for? Well, it gives you an idea of LV ejection fraction. So again, added information to what you're getting from your long axis view. You can see the RV versus LV wall thickness, and you can see LV wall motion abnormalities. So when people talk about regional wall motion abnormalities, that is often found in this view. You can see septal movement. You can see the pericardium. The pitfalls of this, and this is also a great view to compare RV to LV size as well. The pitfalls are important. Remember, pitfalls are always important because you have to understand the limitations of your ultrasound. So inaccurate angle of the LV gives the illusion of wall motion abnormality. So that's incredibly important. Your LV should be circular, not elliptical. That's incredibly important, because if you have an elliptical LV, you will not be able to assess it properly and the wall motion properly. As you can see here, you're unable to visualize the RV free wall, so it's really hard to fully estimate RV size. However, certainly the pressure and volume effect on the interventricular septum can be seen very nicely on a short axis view, and we'll talk about that later. The apical four-chamber view is a view from the apex, as you can see here in this cartoon, and you can see all four chambers of the heart from here. Okay, so as you can see here, this yellow line has now moved to the apical plane here, and you can kind of get an idea that if I were standing on that yellow line, that this is the view of the heart that I would see, right? As if the probe is here at the apex of the heart, okay? And typically, the probe marker, so remember, first we started with the marker towards the patient's right shoulder for that long axis view, then we went 90 degrees to the left shoulder for the short axis view. Now we have come to the apex in the patient's left side of the chest, where you would expect the apex The PMI might be. It's a little more lateral than you would think, and this is where you're getting your 4-chamber view. The probe marker in this view, as you can see here, is pointed towards the patient's axilla. Again, here, and in this picture, you can kind of see the patient is on their left lateral decubitus, and the dot here is towards the patient's axilla. This is probably one of the most challenging views. So if you have all the other views that you're doing while the patient's flat, and you try to do this again while the patient's flat, this is going to be the hardest view to get. Sometimes you can get it when the patient is flat on their back, but oftentimes in order to improve the view, this is the point in time at which you might ask the patient to definitely move into their left lateral decubitus position. One of the techniques that we cover with beginners is that if you slide the transducer from the short axis location towards the apex and aim the probe from the LV apex with the dot towards the right shoulder, this is, aim the probe from the LV apex and aim it towards the right shoulder. So see here, you're sort of aiming up towards the right shoulder. Then you'll get your 4-chamber view. So see, this arrow is showing sliding from here, which would be the short axis view, and just sliding over to the PMI. And the reason that that's helpful is because often if you were, I'll go back to the slide, if you were to lift the probe from this part of the chest and just move it to the PMI, you might not see anything. And so that can be quite frustrating for beginners especially, and not knowing where to troubleshoot in order to get your view. So if you slide the probe from the short axis location, it keeps the heart in view as you move into the PMI location. So what do we see in the 4-chamber view? So the septum, probably one of the most important things, should be oriented vertically in the center of the screen, okay? As you see here, the septum should be oriented vertically, okay? It should be bisecting the apex. Remember, the apex is here. You should be able to see both ventricles and both atria. This is, again, as you can see here in this cartoon, on the left side of the screen of a patient that's in an ICU bed with wires and things like that all over the place. This is classically, this is my setting. It's quite difficult to get this view in our ICU patients, but this is the view that you're looking for when you do the apical 4-chamber view. This is what it looks like dynamically. Now, the question that I always ask everybody when we're looking at this, okay, is which chamber is which and how do you know? Well, that question is important to understand, and I'm going to go back just a second to help us answer that. So if you could see here, the dot is towards the patient's left shoulder, right? So that means that whatever is closest to the dot on the screen will be closest to the dot on the patient's chest as well. And if you look here, the right ventricle would be here, the left ventricle would be here, right? That being said, when you flip the image on the screen, that's exactly what it looks like, because the marker is here on the right side of the screen, and on the patient, the marker is towards the patient's left axilla, right? So that means that whatever's on the left side of the patient will show up on the side where the marker is. So imagine that the marker on the screen is here on the right side. Then again, you're going to have your left-sided structures that are closest to the marker on the patient are going to be similarly so on the screen. Okay, so again, the marker on the ultrasound screen will be on the right side. However, when you are scanning the patient, the marker on the patient is pointing towards the left axilla. So that means everything on this side is towards the left axilla. So this is the left ventricle and this is the right ventricle. Why is it flipped upside down so that the ventricle are at the top? Well, remember again that whatever is at the top of the screen, okay, is what's closest to the probe marker, or excuse me, the probe itself. So if you're looking here on this image, the probe is basically sitting here at the apex. So the apex is what's going to be the first thing on this top of the screen, because that's the first thing that the ultrasound probe is seeing, right? So again, that explains the whole reason why you're seeing this image like this. So on the right side of your screen are the left-sided structures. So left ventricle, left atrium, right ventricle, okay? Now, the apical four-chamber view, what is the information that we can get from it? So this is a great view because you can see all four chambers. Of course, it's a little bit challenging, but this is a great view to compare right to left ventricle and really assess the size difference. Many people will say, well, this must be the left ventricle because it looks bigger. Remember, again, that we can't make that judgment because patients who have severe RV dysfunction or RV failure will basically have a larger and potentially thickened RV, right? So we can't base that on size. So that's why we have to understand the orientation of the structure so that when we're assessing RV to LV size, that we know which structure is which. We can assess septal movement, evaluation of the tricuspid valve and mitral valve anatomy. You can evaluate the left atrium and right atrium. You can get a good view of your right ventricular function as well. What are some of the pitfalls? So as I mentioned several times already, this is quite difficult to obtain, particularly in critically ill patients. It's challenging to acquire an on-axis image. And why is that? Because that particular area, if the patient's not in the left lateral D cube, you're imagining that you're in that PMI location and you're trying to get this view and you're looking in between ribs, and it's often you lose that view as you start to tilt upward to get the view of all four chambers. So the next view from the apical four-chamber view is the subxiphoid four-chamber view. So there are two ways that you can get four-chamber views, the apical and the subxiphoid. Often in critically ill patients, this is probably the easiest one to get. In this particular view, the transducer placement is right below the xiphoid. What I like to also tell people is that the liver is your friend. It allows for the sound waves to travel nicely through the liver and reflect in such a way that you're avoiding bowel gas from obstructing your view. So the liver is a really great acoustic enhancer. So the transducer placement right below the xiphoid can actually move a little bit towards the right side of the patient so that you're below the liver. You typically want to hold the transducer from the top. So as you see here, the scanner is holding the probe from the top, not from the base. Okay, so the whole hand is sitting on top of the transducer. And the reason for that is because that way it allows you to flatten the transducer, because as you can see here, you really want to be somewhat parallel to the way the heart is sitting in the chest. And in order to do that, you have to actually flatten out the probe so that the face of the probe is actually, this is the heart, but the face of the probe is actually parallel and looking at that view, at that plane. The transducer marker, which is the marker on the probe itself here, is at 3 o'clock. So basically towards the patient's left side. What do we see in the subxiphoid four-chamber view? Well, you see all four chambers, but what does it look like? Well, remember that the probe is sitting here in your subxiphoid region, and the first structure it's probably gonna see is the liver, right? So that's the first thing you see. After the liver, what's the next structure? Right ventricle. Then you have your tricuspid valve, right atrium, mitral valve, left ventricle. Okay, so again, you're seeing that in this cartoon as well. This is what this looks like dynamically. So again, left ventricle, left atrium, here's your mitral valve. This is your right atrium, your tricuspid valve, and your right ventricle, and this is your liver that you're seeing above here. The available information, just like every other view, we have to know what we can find on this. This is probably one of the best views for pericardial effusion and tamponade because you can see the entirety of the the entirety of the pericardium. You can also then quickly go from this view to the IVC. And this is often the best view for assessments of RV function and RV overload. It is a bit uncomfortable for the patient, and again, if you're off axis at all, it can be a real problem to giving you misinformation. So how do we go from subxiphoid to the IVC view? So from the subxiphoid four-chamber to the IVC, we focus on the right atrium, fan the probe inferiorly to follow into the IVC, and then you're going to rotate the probes. As you see here, you're going to rotate the probe so the indicator is towards the patient's head for a long axis view because we want to see the IVC. typically in a long axis view. So here, you're looking at the IVC in a transverse view, okay? You're looking at the IVC in a transverse view, and this is the IVC here. And then as you flip, this is your longitudinal view, and you're seeing the IVC in the longitudinal view here. Again, subxiphoid inferior vena cava, incredibly useful for pericardial effusion assessment, because this is also where you can see a plethoric IVC, how you can assess the size of the IVC to help you determine that. Certainly, it is used quite a bit with volume resuscitation, although, of course, there are several limitations to that. And then just again, to identify that the liver can truly be your friend to provide a nice acoustic window. Always one of the most important things, please remember the IVC and aorta look very similar, and a patient who has very significant respiratory drive, which causes swings in the intrathoracic pressures, can make the IVC almost look like it's pulsating. So I would be very hesitant to think about that the difference between IVC and aorta is because one is pulsatile and one is not. In this particular image, you can see this patient's IVC looks like it's pulsatile. If I didn't know any better, then I would wonder that, is this the IVC or is this the aorta? How do I know that it's the IVC? Well, one, I can see it dumping into the heart. I can see that it's coursing, what looks like it's coursing through the liver. And if I was able to fan a little bit, and this is of course one dynamic view, I'd be able to see hepatic vasculature dumping into the IVC. So those are the ways you can differentiate IVC versus aorta. The aorta, which I'll show you in a minute, also falls above the spine. So again, IVC available information, the size and dynamics of the IVC can reflect your right atrial pressures. The actual interpretation of which is a bit more sophisticated. I'll cover that in a later lecture, but again, really don't want to focus too much on that. I just want to focus on the general big picture. Pitfalls, mistaking the aorta for the IVC, which I want you to pay attention in this picture here, what's happening. If you're looking at the IVC should run within the liver. You should see hepatic veins coursing through, and the aorta, which will almost look like it's at the bottom of the screen, will sit above the spine. So this is the IVC, this is the aorta. Okay, very important distinction. So this is the final picture of all of the 4 views that we talked about, the 5th view being the IVC. And then I'm going to pause here while I open up the next lecture. I can take a minute for questions if there are any right now. Otherwise, I'll keep moving, since the first lecture always takes a little bit more time. Hopefully the next 2 will be a little bit quicker, because we've covered a lot of the ground and the foundation in the first lecture. So Denisse, if there are any questions I can answer now, happy to do that.
No questions so far in the chat.
Okay,
please,
sounds good.
Please, everyone, if you have any questions, feel free to add it in the chat so Dr. Nahreen can respond to it along the presentation.
So the second part of this cardiac ultrasound presentation, I'm going to focus mostly on LV interpretation and a little bit more on IVC. So again, remember the 4 views that we talked about and our 5th view, which is the IVC. So I'll talk a little bit more about the IVC and what it means. So remember, we just covered this in the last lecture, that the IVC in the long axis view is probably where we get the majority of our important information that we can from the IVC. Use the hepatic. So remember, again, we need to make sure that we know that the structure that we're looking at is actually the IVC. So here it's quite clear, right? You can see it dumping into the heart. You can see periodically as this image comes in and out that you're seeing a hepatic vein here dump into the heart, dump into the IVC. So you want to use those as your signposts. Traditionally, when we talk about IVC collapsibility, we measure the collapse about 1 centimeter distal from the point of the hepatic drain into the IVC. So 1 centimeter distal from the point the hepatic vein drains into the IVC. Now, transverse versus longitudinal. Oops, excuse me. Let me go back. So in the transverse plane here, this hyperechoic line is actually the spine. And what you're seeing right above the spine is the aorta, which clearly here does look pulsatile. I'll give you that, right? And next to it is the IVC. That's in the transverse view. In the longitudinal view, you see almost like bunny ears here with your hepatic veins, okay? Sorry, this is still transverse view. You're seeing your bunny ears here. Again, your aorta, bit of your spine here, and your IVC, okay? IVC versus aorta, again, this is incredibly important to be able to determine the difference between the two. So normally I would pose this to the group, but the image on the left is the IVC, which is sitting, excuse me, the aorta. Again, sorry, the image on the left of your screen is the aorta. You can see it sitting above the spine here, okay? You see your liver above. Here, you see your liver on either side of the IVC, on either side of this structure, which basically gives us a clue that this is IVC. You see the IVC dumping into the heart, and occasionally you see some hepatic vasculature dumping into the IVC. Now, what if in that subxiphoid view, all you see is this? Well, remember, when we looked at lungs, the lungs cause scatter, and what's in the lungs? Air. So in normal aerated lungs, that causes scatter of the sound waves. So any other air-filled objects in the, or structures in the body will do something similar. So if you see this, the explanation for this is actually bowel gas. Now, what do you do to get a better image of the IVC if that's all you see? You can go through a transhepatic view, which is the right alternative flank view, which can also give you a view of the IVC and aorta from the side, which is typically a little bit easier to get if you're unable to get it in the subxiphoid view. Measuring the IVC, I'm going to skip that for just a minute because it's a little more complex and I want to get to some of the more important meat of this lecture. This is a really important point. If the IVC is plethoric, that is a non-specific finding, and things to think about are all of these diagnoses that are listed here. So congestive heart failure, tamponade, restrictive cardiomyopathy, all things that will cause a plethoric IVC. So I want you to keep that in mind. So plethoric IVC is a non-specific finding and can be found with all of these diagnoses. Probably one of the ones that I like to point out specifically that's most important and most life-threatening is a plethoric IVC in the setting of a pericardial effusion. A plump, non-changing IVC is probably the most sensitive ultrasound finding for tamponade. Similarly so, a collapsible IVC is also quite nonspecific, and here are all the reasons, all the etiologies behind that. Severe dyspnea, so as I mentioned, that large shift in the intrathoracic pressure can really cause the IVC to collapse, and that can be quite confounding. Abdominal breathing can also do that. Valsalva, tense ascites, abdominal surgery, hypovolemia, distributive shock, tricuspid regurgitation, all of these different things. So in order to identify one from the other, you have to be able to find other findings that support the diagnoses. In general, this is something that is still debated quite a bit, but the one thing to keep in mind are the extremes of the IVC are probably most helpful. A very flat IVC is very helpful, and a very plethoric IVC is helpful. Anything in between is a bit challenging. So when you're thinking about how that correlates with right atrial pressure, which we're talking mostly about the correlation with CVP, greater than a 2.1 centimeter diameter of the IVC typically correlates with right atrial pressure. If there's more than 50% collapse, with a right atrial pressure of 5 to 10, if there's less than a 50% collapse, 10 to 20, and if less than 2.1 centimeters, then with greater than 50% collapse, 0 to 5 is usually the estimated right atrial pressure, or 5 to 10 if there's less than 50% collapse. This is a little more higher level than what I want to cover, but I think it's important because it's probably one of the most frequently asked questions about IVC. So the next thing I want to move on to is the left ventricular ejection fraction and how we utilize the 4 views that we talked about in assessing left ventricular ejection fraction. This is not a quantitative assessment. This is going to be a qualitative assessment. And the reason for that is because in point of care ultrasound, the concept is really to get a quick diagnosis, a quick assessment with a quick diagnosis of why the patient might be ill. So in order to quantify left ventricular ejection fraction, there's definitely a more complex approach to that. We're not going to cover that in this lecture. We are going to cover the qualitative ways in which to assess left ventricular ejection fraction. So the first 3 things that you look at are in the left parasternal long axis view. So what are those 3 things? The endocardial excursion. So how are the walls coming in and out? The myocardial thickening, are the walls thickening on contraction? Septal motion of the anterior leaflet of the mitral valve. So as the mitral valve opens, that anterior leaflet should come up nicely towards the interventricular septum. So knowing that those are the 3 things we look at, let's talk about that a little bit in a little bit more detail. So looking here, we have 2 different images with 2 different ejection fractions, okay? The image on the left side, I want you to pay attention to what's happening to the LV diameter change and what's happening to the wall thickness here. As systole happens, you're seeing the wall thicken, right? Now here, on this side, you're not really seeing much LV wall excursion. You're not really seeing much wall thickness change. And then the last thing is focus here on the anterior mitral valve leaflet. Here in this image, you're seeing the leaflet come nicely up to the interventricular septum. So this isn't, remember, in the long axis view. So that means that this structure here is the left ventricle. This structure here is the left atrium, aortic outflow tract and aortic valve, and your RVOT. So as we're looking at the left ventricle here, all those 3 things we just talked about, endocardial excursion, myocardial thickening, and the anterior mitral valve, all those 3 things seem to follow nicely that this LV ejection fraction is quite normal. Whereas here, the LV diameter is barely changing. The mitral valve anterior mitral valve leaflet is nowhere near the interventricular septum, and there's barely any wall thickening happening there. Now, there is something mentioned on the prior slide called endpoint septal separation. All that is a measurement of how far the anterior mitral valve leaflet is from the interventricular septum. So distance between mitral valve and septum during diastole. This is something that is measured using M mode. And what you're seeing here, this is the movement of the anterior leaflet of the mitral valve during diastole, and the measurement here is in between the anterior leaflet of the mitral valve and the interventricular septum. This is RV, this is the septum, here's the LV cavity, and you're seeing here the mitral valve, anterior leaflet of the mitral valve being measured in between this peak and the interventricular septum. And this EPSS, this distance, is 0.68 centimeter. What the heck does that mean? So what does that mean? That means that the distance between the anterior mitral valve leaflet and the interventricular septum is 0.68. Normal cutoff is around 0.7. Anything less than that is indicative of the mitral valve leaflet being nice and close to the septum. Anything more than that means that that anterior leaflet of the mitral valve is far away from the septum. So in this image, as you can see here, very, very obvious difference that your anterior mitral valve leaflet is quite far away from your interventricular septum here. And that measurement was measured to be 1.64 centimeters, so greater than 0.7. So then how do we use the short axis view? So now we understand, okay, we have all of these things from the parasternal long axis view, but we know from the last lecture that we can't use one view to make a judgment. So now we want to look at our short axis view because that's the next view that we're going to go into. Remember that from the long axis view, which was started with the dot towards the patient's right shoulder, now we've rotated the probe so the dot is towards the patient's left shoulder, and we're looking at the short axis view now, right? So in the short axis view, this is what we see. And it's best judged at the level of the papillary muscles. So this is why I mentioned that as a beginner, the #1 view in the short axis that you want to look at is the papillary muscle view. At the mitral valve level, you're underestimating the ejection fraction. And at the apical level, you're overestimating. So as you can see here, this is what I would say is at about the mitral valve level. This is at the papillary muscle view. Okay, and you can see that difference. Okay, so let's look at this in real time. What I want you to focus on is the dot in the center of the screen. The dot in the center of the screen is basically your reference point. If you imagine that you are that dot, or you put your finger where that dot is, in a normal ejection fraction, those walls should come together nicely as if they're coming and biting your finger. In this view, however, on the right side, if you think about that change in the size of the cavity should be such that there should be fractional shortening from the diastole to systole of 1/3. Okay, 1/3. That correlates with normal ejection fraction. And in this view, on the right side, you're barely seeing those walls come together. Your finger is sitting there and the ventricle is barely moving to come and grab your finger. It sounds childish, but it's actually probably the most widely used way of thinking about this. So in conclusion, with left ventricular ejection fraction, we have a real-time information to integrate with our clinical data that can give us a view of why the patient might be short of breath, hypotensive, et cetera. And really, before you scan for all of these lectures, I want you to remember your clinical question has to be in your mind before you start scanning, because you're looking for specific answers to these questions. Again, probably one of the biggest conclusion remarks, never settle for a single view. Make sure that you're getting all of your views. Remember, there are 4 main views that you look at for the heart, and then the 5th view is the IVC. So I'm going to pause there and go into the last lecture, which is going to cover more pericardial effusion and RV interpretation. And this should also be a somewhat quick review as we've gone through the meat of cardiac ultrasound, which is in the first lecture. So we'll go through pericardial effusions and tamponade, which we talked about a little bit on the last lecture, and we'll talk about RV evaluation, and then I will stop for questions. So pericardial tamponade, remember, it's not about the amount of fluid, it's actually about how quickly the fluid accumulates. A rapidly developing pericardial effusion will have a rapidly increasing intrapericardial pressure, whereas slowly developing pericardial effusions may take a little more time to reach those similar pressures. In tamponade, the subxiphoid view is the best. We've already covered that, right? So subxiphoid, under the xiphoid, your marker is pointed towards the patient's left. So here you can see the indicator on the probe is towards the patient's left. As the pericardial pressures increase, the IVC first becomes unchanging, and then there is right atrial collapse and then RV collapse. That's usually the order in which you see things. And you can see here, RA collapse, RV collapse. We mentioned this in the last lecture, IVC plethora, so that distended, non-changing IVC has very high sensitivity when it comes to tamponade. Again, another beautiful view of subxiphoid, from the subxiphoid view. And why do I know that? I know that because this is the liver. And remember, in the subxiphoid view, the first thing at the top of the screen is the liver. Then what you're seeing here is left ventricle, right atrium, left atrium, and you're seeing this beautiful anechoic area here, and that is a very large pericardial effusion that is causing collapse of the RA and RV paradoxically. This is a view of parasternal long axis with tamponade. How do we know it's the long axis view? So remember, go back to your basics. First of all, in a parasternal long axis view, you know that the RVOT will be at the top of the screen. Your left ventricular outflow tract will be the next structure. Then you'll see your LV and your left atrium. Everything looks crazy in this image because the effusion is throwing everything off. But if you can identify your structures, you'll know what kind of view you're looking at. Of course, obviously, if you're the one doing the scanning, you'll know exactly what view you're doing because you're the one holding the probe. And as you can see here, you can beautifully see this effusion. Now, what's really important to recognize is that pericardial effusions will always fall above the descending thoracic aorta. A pleural effusion will fall behind the descending thoracic aorta. Next thing, in the short axis view, what is tamponade, or what does a pericardial effusion look like? As you can see here, you're seeing your short axis view. Okay, your left ventricle, that nice circular appearing structure. Your RV, that's here, and you're seeing that anechoic structure around. There is likely also a pleural effusion here as well. What does tamponade look, or effusion look like from the apical four-chamber view? Remember, now you're at the apex, you're near your left side of the chest with the marker towards the left axilla, and you're getting your four-chamber view, and this is what this looks like. So your left ventricle, your left atrium, right ventricle. You can't really see the free wall, so it's a bit difficult to tell, are we in tamponade, but you can very clearly see here this pericardial effusion. So then moving into the last topic, which is RV assessment. So there are four main things that I want you to think about, because there are four main views that you're looking at, right? So in the parasternal long axis view, we can see the RVOT, but that does give us at least the first indication is the RV big. The next is the short axis view. Normally, the RV should look crescentic in size. It should be adjacent to a circular appearing LV. So this is a great way to look for RV versus LV size and the septal kinetics that can happen with enlarged and overpressurized RVs. The apical four-chamber view, this is a great way to visualize RV, LV size right next to each other. And remember that in a normal heart, the RV should be triangular. And as you see in this animation, the LV should really take up the majority of the apex of this view. If the RV increases in size and starts to take up some of the apex in this view, then you know that the RV is large in size. Subcostal view, similarly, the RV should look triangular normally. This is another good way that you can assess RV to LV size comparison. So the rule of thirds. So in the long axis view, how do we identify a dilated RV? Well, remember, it's only one view, so it only gives us one piece of information, but the RVOT, the aortic outflow tract in the left atrium, should be approximately the same diameter. If I was to draw a line across like this, they should all be the same diameter. So in this situation, you're seeing the left atrium and the aortic outflow tract appear about the same size, but this structure, the RVOT, seems a lot bigger than these two structures. So by using this rule of thirds, a qualitative assessment, you can see that the RVOT looks quite generous. But we need to understand, what does it look like in the other views? And does that then give us some more information that corroborates the initial view? So then we move into our short axis view. So again, remember, long axis view, dot towards the patient's right shoulder. You rotate in your short axis view with the dot towards the left shoulder. You're looking at your short axis. So that means you should see normally a circular left ventricle and a crescentic RV. But in this picture, in this video, you're seeing an LV that the interventricular septum is sort of flattening, and you're seeing what looks like a pretty large RV cavity. This is what we call D sign, with that septal bowing and that paradoxical septal motion. Then we move into the apical four-chamber view. This is what we call the quote-unquote money shot. The reason we call it that is because you get the best view probably of RV to LV comparison. And if you only had one view, if you really had to stick to saying, okay, I couldn't get any other view and I only have one view, the four-chamber view, whether apically or from the subxiphoid, is going to be the best view for you to make your assessment. Again, we always frown upon having only one view, but we understand that some patients it's difficult to acquire. So that is the best advice I can give. This is where you can see RV to LV ratio. You can assess the TAPSE, which is the tricuspid annular plane systolic excursion. And basically what that's measuring is the tricuspid annulus should move up and down with the movement of the RV and the RV wall rather. And so the more movement, the more excursion, the healthier that RV wall. So the less excursion or the less movement of that tricuspid annulus, as you can see here on the right side, the less healthy the RV wall. So this is a great way to be able to eyeball that. Now, RV dilation in an apical four-chamber view, much like the apical four-chamber in general, can be a little bit misleading if you are off axis. The primary error here will be an underestimation as long as the LV is centered. In this picture, we're looking at the tricuspid annular plane systolic excursion. So what I just mentioned, also referred to as TAPSE, more regularly referred to as TAPSE. So how do we measure this? So again, we're using M mode for this. And typically what's happening here, you have your image of the four chambers of the heart in your apical four-chamber view. You place your M mode line at the tricuspid annulus and you hit M mode and you get this weird looking view. And what you're looking at here is the tricuspid annular excursion, and you're basically measuring from crest to from crest to crest here. So the lowest part of your excursion of the tricuspid annulus to the highest part here, and you're measuring that distance. Typically, that distance should be, the more excursion, the better. The less excursion, the worse, right? So that's kind of the way to think of it. So your tricuspid annulus excursion should be about 1.6 is the normal. And so really, again, thinking the more excursion of the tricuspid annulus that you get means that RV is moving, that RV wall is moving nicely. The less excursion of the tricuspid annular plane, the worse that RV is moving. So that is the most important takeaway from that. TAPSE is probably what I would say a little bit more of a higher level concept, but you can eyeball the TAPSE just by looking at what we're talking about here with the tricuspid annulus, which is moving nicely with the wall, whereas here the tricuspid annulus is really not moving very well. So you can see, again, a good healthy RV, a not so healthy RV. What are the other things that we see in this picture? RV to LV ratio in the subxiphoid view. You're also seeing wall thickening here as well. So here you're seeing a nice triangular RV with good tricuspid annular movement. Here you're seeing a thickened RV. It's not very crescentic, it's quite large. In fact, it's almost bigger than the LV here. And so you're really noticing these characteristics of RV dilation and RV dysfunction. The last few things we'll talk about, IV hypertrophy. You can measure the RV wall thickness in the subcostal view, which can really help you answer acute versus chronic right ventricular failure. Remember, we have patients who are hypoxemic for a prolonged period of time who can have RV hypertrophy and RV dysfunction, which can be chronic. And those patients will have a thicker RV wall, whereas you might not necessarily see that in acute massive PE that would cause RV dilation or an RV dysfunction without necessarily seeing a thickened RV. So speaking of PE, there is a finding with PE, going back, something called McConnell's sign, where you're seeing this asymmetric movement of the septa, of the apex here. It's described in the literature as associated with acute right heart failure also. And mainly the reason for that is just because you're seeing a regional wall motion that's associated with lack of adequate coronary blood flow to that area. It's not actually specific for PE, but it's described pretty well in the literature as something that's found with pulmonary embolus. Now, certainly in the right context, if you were to see that and also see other evidence of PE, for instance, such as here, you're seeing clot in transit. Okay, you're seeing some clot in transit here. Okay, that of course would increase your threshold to call this patient a patient with a massive PE. Now, what are the conclusions? So subxiphoid, clearest view for tamponade. Apical 4, best for RV assessment. Again, never settle for a single view. And I'll end with this view of the main 4 views that you're looking at. So I'll review it again. Long axis is at the top left of your screen. And in the parasternal long axis view, the dot is towards the patient's right shoulder. Okay, and if you do that, you're getting that nice long axis view. You then rotate with the dot towards the patient's left shoulder, and you'll get this view up here, which is in the top right of the screen, and that's your parasternal short axis view. Then you'll come into your apical 4-chamber view, which you'll slide from the short axis into where your PMI is. And then from there, you'll get your subxiphoid view, which is under the xiphoid, which is again, another 4-chamber view. Lastly, again, I just want to conclude with this. These links that I've put on here are extremely helpful for you guys to go back, to re-review all of this, to expand your knowledge, to do a little bit of self-directed learning. I highly recommend it. And then I put my email on here as well. I'm open to people connecting with me after this. If you have questions or cases that you want to review, I'm happy to do that. So I'll pause here. I know I went over by a few minutes. So I'll take any questions or comments at this point.
We have a question from one of the attendees. It says, please, can you review the transverse versus longitudinal view of IVC?
Sure.
Thank you.
Okay, so in the transverse view of the IVC, basically all of that you're doing to get this view of the transverse view, you're going to be in your subxiphoid, sorry, let me back up. You're going to be in your subxiphoid region, and before you rotate the probe so that the indicator is towards cephalad, you are leaving the probe with the marker towards the patient's left side. And if anything, you'll be sliding the probe towards the patient's liver, and you'll see this image here. And in order to see this, you will have to sort of tilt your probe upward in order to get this view. Okay, so you'll slide over towards the liver, you'll tilt upward a little bit, and you'll see this view of two circular objects, right? Two circular structures. How do you know the difference between which one is the IVC and which one is the aorta? Well, here you see this hyperechoic area, which is the spine. In a transverse, you're seeing a transverse cut here of the spine. And above the spine, you'll always find the aorta above the spine. So here you see the aorta. It is pulsatile, but the more important structure to recognize is the spine that's below it that indicates that you're looking at the aorta. And then adjacent to that, you'll see the IVC. Now, from this view, you'll rotate your probe so that the indicator is now towards the patient's head. And that will give you a long axis view, which will look like this. Okay, this long axis view here, where you're seeing the IVC in a longitudinal axis, and you're seeing it dump into the heart here. And if you think about it, just to kind of help reorient, because you're in a longitudinal view, this marker, because it's pointing towards the head, means that this is the superior aspect or cephalad aspect of the IVC, right? Because it's dumping into the heart. Anything below this way is towards the feet. So this is the more caudal aspect of the IVC. So I just want to make sure I clarify the orientation as well, because that can be somewhat confusing. I hope that answered the question for you.
Thank you so much.
Mm-hmm.
Any other questions? Yeah, you said that's much better. Thank you. That's the response. Thank you.
Great.
Any other questions from the attendees?
And if any of the attendees would like the option to be able to speak their question to Dr. Nahreen, please let Denisse or I know in the chat, and I can turn your microphones on. And Denisse, I think there is another question in the chat.
Yes, I see. Thomas asked, in which view can we find a D shape typical for PE? So great question. So D shape will always be found in your short axis view. So I'll go back to that real quick to give you an idea. So the D shape itself is referring to the shape that the left ventricle takes on when the RV size is dilated and there is higher pressure on that side. So I'll review that real quick. So the parasternal short axis view. So see if you just look at the left ventricle here, you're seeing as the RV goes to systole and diastole, and that movement of the left ventricle, because of the fact that that the RV size and pressure is increased, you're seeing that septal motion, a flattening of the septum, where in diastole, you really shouldn't see the diastole of LV, of the left ventricle. The left ventricle should be filling nicely, right? But what's happening here is that diastole of the LV is somewhat limited because of the fact that the septum is flattening and causing this D sign. And this is seen in the short axis view. So remember, that's with the dot towards the patient's left side. So if I'm holding the probe, the dot is towards the left side. And that's how you get this view of the short axis in order to assess for D sign. And that's seen in RV volume and pressure. So any particular pathology that causes RV pressure or volume overload will create D sign. Great. Any other questions I can answer? Okay. Let's see. Oh, Denisse, I think you guys are planning to upload the recording on the MedGlobal site. Is that right?
Yes. Yes, we will share we already shared the slides, and we will share this presentation. Great.
So both the slides themselves should be available, and then the one for the lecture for this will be has been recorded and will be shared. And then the lung POCUS ultrasound link is also available on the MedGlobal site. So Denisse, maybe you can share that with the group as well again, so that they have that. Yeah. Okay. Great.
Okay, if we don't have any more questions, we can conclude this webinar. Thank you so much, Dr. Nahreen. Thank you so much for everyone who attended this webinar. Thank you for sharing all this knowledge with us.
Sure. Yeah, thank you for having me.
Thank you so much.
Okay, I look forward to being in touch. Thanks, guys.
Thank you, everyone.